I'm Dr Alicia Macro and welcome to Endo Untangled, where we look at all the complexities around endometriosis and pelvic pain and try to start unravelling them for you. This is part 2 of our episode with Dr Marie-Claire Seeley, who is the founder of the Australian POTS Foundation. If you haven't listened to part 1 of this, please go back and listen to it. Otherwise, enjoy. Hypermobility in POTS, and I would say this is another area that I have found coming up again and again in the women that I look after who come in with pelvic pain and endometriosis, that is under-recognised part of the picture, I think, clinically. I feel like I'm starting to train other health professionals, talk about hypermobility, and even some of the most senior endometriosis and pelvic pain clinicians have said to me, I haven't heard about this before, but I can't ignore it. I can't ignore it because it's like once someone's taken the blindfold off, you just keep seeing it. And so like we now pretty much routinely screen for POTS in our patients, I am routinely screening for hypermobility disorders. And as you say, it's a stretchy person syndrome with some sort of genetic and environmental triggers. People will often come in and say, there'll be hints in the history. They're a gymnast. They're a dancer.
They're a singer.
They're a singer. I haven't had that one before.
Yeah, definitely. There's a book actually about that. There's a great clinician in Melbourne who wrote a book on this a while ago about the swimmer, the dancer, the singer, and whether the singing has to do with the slight neurodivergence side that we see in this population, or whether it actually is functionally just that the connective tissue hyperextensibility.
So stretchy. You can do interesting singing. That's why I can't sing.
And I don't know whether you find it as well. I found with a lot of people that I saw, they didn't even realise.
No.
It's not until I've got them to do something and went, whoa, okay, those elbows are not meant to do that.
That's not normal.
And people, so on this, and I know we're going to talk about hypermobility. You're going to talk about it on another podcast, so we won't go into it too much, but people confuse it with flexibility. And actually, if you have unstable joints for most of your life, you develop a lot of contractures of the muscles around those. So people actually can become quite stiff but still have unstable joints.
Yes.
So look, hypermobility we could talk about till the cows come home. But suffice to say, we have over 2,000 people we've seen through our clinic. 70% of people
That's amazing.
have hypermobility. Now, hypermobility is not a disorder in its own. So there are people out in the community who have hypermobility and they have no other issues, but it is a precursor and I think a foundation on which these other conditions can build. And we don't understand 100% what that is, but in POTS at least, one of the things we probably know is those people that they put on those torturous tilt tables back in the 80s, no one was aware of hypermobility syndromes back then. So nobody asked whether those women were hypermobile. They didn't assess them. But we suspect that those people whose vessels did not contract were the hypermobile.
Yes, because of course with POTS, what you've talked about is the automatic nervous system, which should recalibrate without you having to think about it. So you're quite comfortable within different positions and doing different things in different climates. Doesn't work properly. But the other aha moment that I've had over the last little while is the idea that there's more to the story than that. And without confusing things, in someone who's not hypermobile, and I often say this to my patients, I'm not hypermobile. So I'm not a stretchy person, which means my ligaments and my tissues aren't stretchy. But so when my blood vessels aren't very stretchy, if you are a stretchy person, rather than stiffening up and shutting down in the legs and in the pelvis like it's supposed to, perhaps even if there is that nervous system component there saying, yep, it's time to close down. If you're a stretchy person, you just don't have that at your beck and call. You know, you just cannot close down those vessels, which means you get blood pooling in the pelvis, blood pooling in the feet and the legs, not enough in the heart and the head, and, you know, off the symptoms go. And so there is definitely, in my clinical without being a researcher or an academic, there's clinically relevance to POTS and hypermobility. In fact, I sort of wonder how much hypermobility drives some of the things that we see in endo and pelvic pain patients and in POTS.
100%. And the problem is your connective tissue is everywhere. It's in your vessels.
Yes.
It's holds all your organs together.
Yes.
And if you just think about that theoretically, so one thing we know about people with hypermobility is that they're prone to bleeding without a clotting disorder. So they tend to be people that get lots of bruises. If they're females, they probably have heavy periods. And when they have children, they're prone to having large hemorrhages. And that's because actually the platelets that clot our blood interface with the connective tissue. So do all our neurons. So do all those small nerve fibers that are trying to make those vessels squeeze. What we don't know is, are those nerve fibers inefficient, or is it just not actually having the effect because the connective tissue is
the message is getting there, but the tissue is not doing what it should because it can't, which is amazing. And I must say, from a clinical point of view, Sheree Noble, where one of the things that we have done a lot is work together, and which I've really enjoyed as a GP. You don't normally get to spend a lot of time with your local friendly exercise physiologist, especially one as smart as you are, who we would be doing yoga classes, or endo yoga we called it, which was a program that you developed to help the women that we saw with some of the musculoskeletal pain and even helping with nervous system, that sort of thing. And you would be pointing out, to me, what? Wow! Whoa! That's really bendy. I don't know if you can comment on that a little bit.
Oh, absolutely. We would see some of those positions that we would put our participants in, where you would really have hyperextended elbows, for instance, in like what we call a 4-point position, which is where you've got on your hands and knees.
Classic,
and looking at those elbows, I'm like, whoa.
Yes.
Okay. And also in another position we call child's pose, where we're face down and bent at the hips, and some people's legs were
just
quite flat. And then like you bent it and you were like, right. And then the more we saw in this group setting, the more we thought, wow, there's this real cluster here of this presentation of things. And then if I can pick up on one word that you said, Marie-Claire, which is neurodivergence, again, with one of the things that can often come with that is this different way of sensing our body as well. So we've not only got this hypermobility presentation, but the kind of a different relationship that we have that participants had with their body as well, with not having awareness of, either too aware of some things and not aware enough of other things. And it was quite prevalent.
Yeah, so it's almost the signals going out, but also coming back in both directions are struggling.
Exactly.
Yeah.
They're not quite making the connections that they might in someone else.
Absolutely.
So we know the hypermobility population, just to give you a background, has a very high neurodivergent risk, and we've actually done research, and others have done research internationally to show that. So these people have a lot of crossover, and again, connective tissue is also the interface for a lot of our neuronal interactions through the brain. So whether that is causative or associative, we don't know. But what it means is that there's this hypersensitivity that often goes with neurodivergence that is complicating what is also, happening. So they have real organic issues. So by that, I mean, these issues aren't in their head, where these are 100% mechanical issues.
Yes.
You can see that the vessels aren't contracting. We can see the blood pooling in their legs, in their lower abdomen. We know that there's pelvic congestion in these patients, which will lead to those pelvic pain disorders. We know that.
Would you like varicose veins, really?
Correct.
Big open veins in the pelvis, which again we see again and again when we do studies on the women that I see, which means they've got blood pooling in their pelvis when they stand up, which is not where they want it to be.
They need that
which
back
is part of
brain.
that, and in their heart and the places that they need it. So we have talked a lot, and we have decided to extend this podcast a little bit because there's so much more that we need to talk about. And as we've mentioned, we will cover hypermobility and its role in pelvic pain in another episode. And pick up on some of the others. We'll certainly cover neurodivergence and its role in endometriosis and pelvic pain as well, and also bowels too, because again, the other thing about stretchy is stretchy bowel too, and stretchy bladder. So all of those things are part of the picture. So let's talk about some of the things we really want to talk about today because I think if someone is sitting listening to this, lying down perhaps, hopefully we've helped them understand that it's probably not anxiety that's causing their heart to go fast, that there is a genuine problem going on here. And I've loved a meme I've seen circulating recently about people with invisible illness. You're not, and I was thinking this when you were talking about your experience in Uzbekistan. People with invisible illness aren't pretending to be sick; they're pretending to be well most of the time.
Yeah,
absolutely.
And that's a huge effort that they are undertaking. And if you are listening at home, please understand that there are a growing number of practitioners who understand. However, if you're listening to this lying flat with your AirPods in on the bed, what would you suggest first steps might be, Marie-Claire, for someone like that sitting listening to this, who's probably also got pelvic pain, but we can deal with the pelvic pain side of it another time.
Yeah. So firstly, I should say that we do now have the foundation in Australia, the Australian POTS Foundation.
Which you were instrumental, or you set up?
Yeah, I set it up.
Yeah. With your 4 kids.
While I was doing my PhD.
Yeah. PhD, yeah. Overachiever.
Someone actually said to me in the last 24 hours, and I can't remember who because it's been a busy 24 hours, but they said something about overachievers in this group. And I hear that a lot actually. Why are they all overachievers? And my personal experience is, when you face a lot of the attitudes and the difficulties that you face, you very quickly come to the realisation that you're on your own and the only person that's going to help you is you. And it's really like a refining fire that you go through. And it's because of my illness, I think, that I've become aware that so much needs to be done and there's so little time. And I always live with that urgency of, well, today I'm fine, but what happens tomorrow? What if I have another couple of years where, I'm flat on my back and whatever? So it is a bit of an inbuilt thing, I think, in the population who have made it through that journey.
I see a lot of overachievers as well.
Yeah, and look, it might have to do with that, what we call the phenotype, or the makeup of that genetic person that's perhaps hypermobile and so on. And they are, the ASD group, we do know the autistic spectrum group are very gifted, often. And so there's a lot of, things there that just might go with the population.
Yeah. So
what do we say to them?
Might have POTS. What next? What do we do? So and for the GPs who are listening who might have someone like that coming in to see them. So
I'd say for both GPs and people who think they have the condition, do go to potsfoundation.org.au. We have quite a few resources on there. I know the website's not perfect, but we got gifted some money to actually upgrade that, and we've got a lot of training resources. So we have stuff for GPs to go through. We've actually got some assessment tools that would be helpful for them, and then some patient-facing new patient diagnostic kind of brochure that can just give them a bit more information that we can't give all here. I think the best place to go is to your GP, and what I'm finding more and more and more is that GPs are the people that are open to this because they see it. And I think, specialists, they kind of see it, but they're kind of like, it's all a bit of a ruse, whatever. But GPs know their patients. Mm-hmm. They know when people are coming forward and they're like, there's too many of them to be, an accident or anxiety. Now, your GP may not know, but you can direct them to some of these resources, and there are some great health pathways coming out that GPs will use that will help them. The biggest thing is we've got a symptom tracking tool which has been validated, and that's called the MAPS, the Malmo POTS survey. It was developed by a fantastic cardiologist in Sweden called Dr Federowski, and they managed to find in that tool, if they use that survey, it's 12 questions. It's very easy. Takes your symptoms. There's a cutoff score, and if your result sits around the cutoff score, you've got a good chance that you got POTS. So that's a good survey tool to have a look at first. And
it sounds like it's something that you can take with you to your GP.
Absolutely.
Because I think having something physical to start a conversation can be really helpful.
Yeah, absolutely. And then you go to your GP, and one thing that GPs will do really well is rule out any other conditions that may mimic POTS. And so, for instance, if you had a thyroid disorder, you would have a lot of these symptoms. And so if you've got a thyroid disorder that's not being treated, now you can have both, right? You can have POTS and you can have a thyroid disorder, but certainly your thyroid disorder needs to be treated. And once it's treated and managed, if you've still got those symptoms, then we can look at it. Some people have anemia or iron deficiency.
And they often do. Yes,
and they
also heavy bleeders.
So about 50% of people with POTS will have iron deficient anemia that needs treated. And often that's the first thing that they're diagnosed with. The doctor treats it and all their symptoms remain. And that's a good indicator.
Yes. And I think the tragedy is where the conversation stops at you're fatigued and you don't feel well. Let's do your bloods. Let's look at your iron and your B12 and all of those things that are important. And then correct them if needed. And then what's next?
Yes.
And then I think sometimes that's where my colleagues would benefit from some more resources around this to sort of know, oh my gosh, we gave them an iron infusion, we fixed their B12 deficiency, we diagnosed them with celiac disease or whatever we found. GP room testing.
Yes.
So as I mentioned, we have been almost routinely doing a NASA lean test in our rooms. Can you talk through what that is? And do you think that's something that other GPs should be doing as well as looking at?
100%. Now, the problem for GPs is they have 15 minutes with their patient if they're lucky. And the NASA lean test, or we call it the active stand test. So when they used to put people on tilt table, that was where they strapped them to a tilt table, tilted them up, and because they had them strapped, they didn't use their muscles to keep themselves upright. And that essentially makes a lot of people faint. It's not a very nice test and we don't suggest it unless we are unsure of the diagnosis.
Yes, and so just to clarify, the tilt table is really not recommended at all for management, and the fact that we can't get anyone into a tilt test needn't put us off looking into this further.
I would suggest you don't send people with POTS for tilt tables if they really look like they've got POTS, because it's going to make them unwell. It may lead to an unconscious event, and we've seen people who've had fits and sometimes even pacemakers inserted when they're young, and it's not necessary.
Yes.
But what we can do is an active standing test. So when they stand, you have someone lay on a table for 5 minutes, make sure their heart rate and their blood pressure is relaxed and gone down. After that 5 minutes, you get them to stand up in one smooth motion and stand very still. Now, you can lean them against the wall, where they lean their shoulders against the wall. What that does is kind of inactivate the muscles of the lower legs. We tend to not do that in our own clinic. It was called the NASA lean test because the autonomic neuroscience people invented the NASA lean test for testing the dysautonomia in the astronauts.
I love that aha moment that I was just having going, oh my God, that's why it's called NASA lean test.
Yeah.
And I thought it was called the lean test because we're worried that our patient's going to fall over.
No,
okay. We don't lean them either.
It's more to inactivate the lower legs. But often what that means is the patient has to do a bit of a walk to a wall from a bed, and that defeats the whole purpose of the test. So it's better for GPs who have got beds in their clinics is to just stand them up, have the back of their legs lean against the bed so that if your patient faints, you've got no problem with sitting them down. And I would suggest that if GPs have practice nurses, a great idea is on the initial appointment, see the patient, do the Malmo score, the MAP score, and if you think they've got POTS, bring them back to the nurse and get the nurse to do this.
Yes, our nurses do this and they do it beautifully.
Yeah.
And we, just from a practical point of view, often do them when we're doing a care plan assessment with them. So the patient's already booked in with it. We're lucky. Our nurse spends an hour with the patient. In which time that they can do that as part of that assessment.
Perfect.
Which works really well.
Perfect.
And on the POTS Foundation website, there are some downloadable proformas.
Yes. We certainly have a description there, and we're actually going to make an A4 page just on the active stand test. We've got actually an Australian kind of position statement coming out in a journal soon that will have all these points in it. It will be something to refer to for GPs for that.
And what are we looking for? So our nurse, we've taught our nurse how to do this. The patient lays flat still for 5 minutes. We get a baseline blood pressure and pulse, stand them up against the bed, and minutely or so, I find it quite hard to get
Definitely. I mean, I think minutely is really what we really need to aim for. And I would also say that if you have people that are nurses, particularly that are very efficient with doing manual blood pressures, it's more desirable because what you will get is a lot of erroring of your electronic equipment, and that's just the blood pressure's just tanked.
And the rate is probably changing rapidly as well, which the automatic one can't.
So there's a few things we would say in preparation for an active stand test. Number one, maximally we would suggest that it's done in the morning. That's when people's autonomic dysfunction is at its worst, and it's best to do that. Generally, we like them to be fasted, so a couple of hours not eating, because the gut withdrawal of blood can affect the results, and they can get very nauseous when they do the test. We suggest that they don't have tight compression clothes on, because that will give you an abnormal result or probably a false good result. Once they stand them up, we immediately take a blood pressure and we put a pulse oximeter on so that you get that constant.
Right.
And actually you get, your clinicians will get really au fait with seeing how rapidly that heart rate can go up and down. And that what the autonomic nervous system does is it flattens out, it keeps our heart rate and our blood pressure between this very narrow band. When you put on a beat-to-beat recorder like we do, which is really technical equipment, what you'll see is the autonomic nervous system is absolutely working its heart out to keep this regulated. The blood pressure's spiking, dropping.
No wonder people feel exhausted.
Yeah. And you put it on a normal person and you see, just this nice soft pattern going. So you can see the noise of the autonomic nervous system when you get this, integral monitoring. And in fact, some of your GPs out there, if they get Holter monitors done, ask your pathology group or the group doing your Holter monitors for the trace.
Yeah.
And when you see the trace, you'll see the chaos of this fluctuation as the heart's trying to stay in tune. So we suggest manual, but you can use electronic if you're not great at taking the manual blood pressures. Every minute, on the minute, we take a heart rate and a blood pressure. What we're looking for is a couple of things. In terms of blood pressure, if somebody has orthostatic hypotension, which is a different condition but also autonomic condition, their blood pressure will drop in the first 3 minutes and it will stay dropped. And that is orthostatic hypotension. In POTS, the blood pressure actually tends to either go up or it stays normal or around what it has been, but the heart rate will steadily climb, and the heart rate should be not necessarily sustained at the same high rate all the way through, but we would see at least 2 recordings where it's excessive. And we're looking for an actual diagnostic criteria which was set of 30 beats change from when they were lying flat to when they're standing. Now, if somebody has a very low heart rate, so let's say your heart rate's 45 because you're an elite swimmer, when you're laying, we take that 30 beats actually from 60. So you technically should have a heart rate over 90 at least before you diagnose POTS, but more typically we see heart rates up in the 110s, 20s, 30s, 40s, 50s. You see people with extreme delta heart rates. Now, they may get a late blood pressure drop. Often with postural tachycardia, the heart will go hard, and then you get towards the 10-minute and you'll just see it, the heart rate dropping and the blood pressure dropping. If the heart rate drops too low and the blood pressure drops completely, we call that neurocardiac syncope. That's another condition. In POTS, what you tend to see is the heart rate will stay. The blood pressure might drift off, but even if it goes a bit low towards the end, as long as the heart rate's kept up, we call that POTS. So anything over 30, if they're adolescents, there is this kind of, it should be 40 beats per minute between kind of for adolescents up to 19. And if they have an absolute heart rate of 120, so you get some people come in, their resting heart rate's 100. We don't expect it to go up to 130. We're like, if it goes up to 120, that's a diagnosis of POTS. And what is really important here to understand is this diagnostic criteria was made, over 30 years ago. And it was made on a small cohort of almost all women. And it was compared with a control group of half men, half women. Now, men actually have higher heart rates than women when you do this test, just typically because men, if you want to think of it evolution-wise, they have a lot more fight and flight response than women. So that heart rate that it was set to the higher men, watered down the women's. And so what I'm trying to get at here is the 30 beats is not strict.
Yes.
I mean, and if somebody clinically looks like they have POTS, you've ruled out everything else, their survey result is high, and they've got a heart rate over 25, I would be repeating that test. Yeah. And in fact, we get a lot of our patients to go home and do their standing tests, and you might have just got them on the day when they're actually not as bad as they've been other days, and then there's days where they can't get out of bed because their heart rate's 200. So one negative test does not rule out diagnosis of POTS.
And so is it recommended that a patient be sent for an echo and a Holter, so an ultrasound of the heart and a 24 or 48-hour reading of the heart? Is that part of
so I would say, we do that because we're a cardiology clinic.
Okay.
And, over the 2,000 patients that we've seen, have we picked up structural issues? Yes. Yes, but very rarely.
Yes.
But it is important to note that in the hypermobile population, they are prone to this mitral valve prolapse.
They've got floppy.
Correct. Floppy. And in a few of the ones that we've picked up, there have been significant structural issues because this population kind of merges over into those connective tissue disorders that affect the actual size of the aorta and also some structural issues in the heart. And so it's been, in the few people that you pick up, it's quite a profound disorder.
It's probably worth.
And I think it's worth, if you've got the mitral valve prolapse sitting there, then as a clinician, as a GP, that patient probably needs another echo in 5 years' time, whatever is suspected. Holter monitors likewise. You do get a couple of these weird syndromes, Wolff-Parkinson's Whites, and, some pauses and different things is rare. But I think the Holter monitor is helpful as a diagnostic adjunct for most clinicians, in that the average heart rate over 24 hours is a really good indicator that this person possibly has POTS. What you want to look at is the trend. Does their heart slow down at nighttime, which typically in most POTS patients it would. You get the occasional person that doesn't, but in most of them it does. And is most of the tachycardia over the day?
Yeah.
And GPs can actually ask their reporting group for that. A lot don't know.
What's the average daytime? What's the average nighttime?
Yeah, and you can ask them for the trend, and you will see in a trend, does the heart rate settle down at nighttime? And I would look at that period in the morning when they get out of bed, and you see these incredibly sharp rises. The heart rate goes in some people from 50 up to 120 straight away.
Yeah.
And, if you don't want to do a Holter or you don't think it's indicated, almost everybody in this population wears a wearable watch these days. Literally just go look at their trace over the last 5 days and look at the 7 or 8 o'clock in the morning, or ask them when they normally get out of bed.
Yeah.
You will almost instantly know if this patient has POTS or not. Yeah,
absolutely.
Okay, so in the remaining few minutes that we have, we could literally do this for an hour and talk for another hour or more.
I think, as Marie-Claire said, that it's probably its own podcast.
Oh, it definitely needs its own podcast. So management.
Yeah.
So there's probably a few parts to this, but often lifestyle changes are where the real bang for the buck comes. Most of the benefit often comes from that, in my perspective, and then there's some fancier things and there's medications which, yes, are often needed. But what are the first things that someone can start doing from a lifestyle point of view that make a difference?
And I think lifestyle definitely is a bang for buck. It often goes in conjunction with some people with medications, but we definitely start with lifestyle. So we have to always think around this fact that this essentially is not enough blood coming back to the heart. And in medical terms, we talk about that as preload, or the load of blood into the heart. We need to maximise that. And how do we do that? We need to lift the blood volume. Now, if all these people with this dizziness and so on go and drink 5-6 litres of water, it's not going to help them. Their body is peeing out anything that it perceives as excess. And in POTS patients, we know that there is a problem with that system that controls that. And so they probably pee more than the average person anyway. And that, for your clinicians, another question is, to ask them is, do they get up at night time to go to the toilet? And the answer is often yes. In young people, that shouldn't be the case. So we need something that keeps the fluid in their body, and that is salt. Now, unfortunately, fortunately, or whichever way you look at it, our whole society has been keyed to think of salt as the devil.
Mm-hmm.
Salt is considered the devil because it lifts your blood pressure, and high blood pressure can affect the walls of the vessels and the arteries over time and lead to stroke and heart disease. But in young hypermobile people, that is not the problem.
Mm-hmm.
The problem is not enough blood pressure. So in generally speaking, in a young person, unless they have some other significant disorder, there is limited risk to increasing salt.
Absolutely. Salt is not the enemy here.
No.
You need more, and it will not give you a heart attack. I say that day in, day out in my clinic.
Yeah.
How much salt?
Yes. So the actual studies that showed that salt was effective, they were telling people to take it for years and years and years, and finally somebody actually decided to do a study on it and did a really good study. And in that, they took massive doses of salt. I need to say it was salt on its own, so it wasn't salt with sugar. A lot of people are told, in hydrolytes you have to have sugar or the salt doesn't work. That's not the case. Salt on its own will lift your blood volume. For moderation purposes, generally the advice is to have 2 teaspoons of salt a day. You could do 2 teaspoons on top of whatever is already in products. Really, that would be beneficial. Now, most people, you can get salt in tablets, but the problem is people with this condition have gut issues.
Mm.
And if you put a salt tablet down your gut and it sits in the stomach for extended period of time, you're going to end up with actually, gastritis and different problems. And it's almost never tolerated very well. It makes people feel nauseous. So the best way of getting salt is through diet, but also through hydration drinks.
Mm-hmm.
You mentioned Sodi before. That's an Adelaide-based company that does hydration drinks. They have no preservatives, and they actually have a very low glucose in them. So that's quite a beneficial way. You get both the volume in there, and you get the salt that tricks the kidneys into maintaining the fluid in the body. And so we look at, for people were saying about 4,000 milligrams a day of sodium. So I think in a sodi there's 1,000.
Right. So about 4 sachets a day kind of.
Yeah. I mean, generally people aren't going to be able to tolerate that. So what we usually say, particularly to young girls, is get up and have your kind of boost of salt drink in the morning as much as you can. And they did a study on boluses, chugging down 500 ml of water, and it affects your blood pressure very quickly, but only for a certain amount of time. But in the morning when people feel the worst, have the worst symptoms, that's a good idea to do that. If you got at least a sodi in the morning and then maybe one at night, and then try and have high salt diet. Be careful about high salt diets. They often go with junk food, but we try and really encourage people to get it through soups, miso soups and salty good.
Miso's good.
Yeah, things. Of course, it's easier in the winter to get a high salt diet because you can have lots of soups, but it's the summer that we really need this.
What about Salvital? I've heard some other long COVID clinicians talk about Salvital, which I find in clinic, if someone's under 40, they know exactly what I mean. If they're over 40, they know exactly what I mean. If they're under 40, they don't know what I'm talking about, because that's probably the time when salt went out the window and no one wanted to touch it anymore. Do you ever recommend Salvital?
No.
Okay. But not...
No, it's not because I don't recommend. Yeah. We recommend the salt loading. We often send people to dietitians, partly because it's outside my scope of practice. But number 2, we deal with a lot of people with gastrointestinal dysfunction. There's a high celiac population amongst this group who have all sorts of other things going on. And so and particularly in the younger girls, you get nausea, bloating, all these things. And so there's some weight issues around there. And so we want to be a little careful around that. And I would suggest that there is a guidance of a dietitian for anybody on that borderline of those kind of issues. But essentially anything with a high salt that isn't high preservative. And the reason for that is, it's another podcast, is that this population have a lot of irritability around these kind of inflammatory allergic
additives and
disorders.
Other things.
Correct. And you want to think about what else is in the product that you're eating.
So I think for listeners is that I think the message that I'm hearing is there is a lot you can do, but it does sound like it does need some guidance. So it's not something you can kind of wing on your own.
Look,
because of the complexity of the nature of this.
I think it depends how dysfunctional the patient is at the time when they come in. But if they're kind of bedbound with this, which sometimes people get to because they've had zero help along the way, they definitely need help. There's so many things to target. But if you've got a 16, 18-year-old, and I shouldn't always go to the adolescent because more than half of people diagnosed with POTS have their onset after the age of adolescence. So adults definitely get this condition. And they will know the point at which they got it. And if it's just been a little while, but they're impacted by it, often just increasing fluid. So we say 3 to 5 litres a day. Do not go more than that. The more you drink, the more your kidneys get washed out and they don't know how to retain fluid. And in fact, I tend to say 2.5 litres to 3.5 litres to most of, because we're talking about smaller women. If it's a 6'4" man, they can go up to 5 litres. The other thing that is really helpful but not as well tolerated is compression wear. And by that, we don't just mean, everyday active wear. We mean compression wear that actually compress and is graded compression. And there's a few brands in Australia that do that, and they're the ones that you'll see with high-level athletes wearing. So they're recovery pants, and 2 times used ones. Supercore is another. Skins was the American brand, I think, that came out. They actually all have some level of compression, and by that we measure that in millimetres of mercury. And so typically we say 15 to 20 or more is really good, and ankle to high waist. What that does, it acts as the compressing agent that the vessels are not doing. So it keeps your blood pressure up. So if you had fluid, salt lifts your blood volume, compression to keep the volume where we want it. And if you will try and avoid some of the triggers, and the triggers for making you worse are all things that dilate your blood vessels. So having hot, long showers, you're standing in heat, is not going to be good. Being in unair-conditioned environment where it's hot, and we live in Australia, so we all know what that's like. But for a lot of people, eating large meals, and particularly carbohydrate-laden meals, carbohydrates release a hormone, and there's been great studies out of the US from Vanderbilt where they've looked in POTS, and POTS patients typically have a poor balance of the insulin glucose response. And in response to that, they pour out a hormone that opens up their vessels and causes this blood pooling. And so often you get young people in, and if you ask them when are they most likely to faint, if they're fainting or feel dizzy, it's after they've eaten a meal. So we break the meals down to smaller meals. We cut the large carbohydrate load down. Most people come back after you say that and they've seen some improvement. This is not a cure, but it is a turning point for people. And once they've done that for a while, the other thing we focus on is, where are they in the conditioning environment? We know that astronauts get deconditioned, their autonomic nervous system gets worse. That's the same for a POTS patient. If you get deconditioned, you're going to get worse. Conditioning, if you get people in who are high-level athletes, obviously they don't need a stepwise program, but we do need to help them get back to where they were.
So a good exercise physiologist who understands, or physiotherapist.
And what I would say up front, it is not okay to send a completely deconditioned or very unwell POTS person straight off to a rehab program. It's not going to work.
Absolutely not.
And you must preserve daily functionality over exercise. So by that, we see people sent off to do exercise programs and then they're
wiped out.
They can't go to school because they're so fatigued. So we start, and we've got some resources coming on the website around how to manage that. There's a great exercise physiologist, Caleb Shield, who's really helped us with that and does a lot of work in this space in how to personalise, individualise conditioning. But the stronger your muscles are, the better the blood return to your brain. The more blood return to your brain through exercise, the better your brain is, the less your brain fog. So the ultimate goal is to get people back there, but it's sometimes a long journey that has to be trodden patiently.
Dr Marie-Claire Seeley, what a journey we've been on today. Thank you so much for your honesty and vulnerability in sharing your story. If we had 30 seconds remaining, is there any last thoughts you'd like to leave us with today?
I think just to those people who have had a light switched on, if you managed to come hold of this podcast, just to know that you're not alone and that there's a lot of light at the end of the tunnel. There's a lot of people living with this condition. It doesn't mean that you can't have a full and happy life, and we just need to give you some tools to manage this better.
Thank you so much for joining me today, Dr Marie-Claire Seeley, Cherie Noble. Thank you so much.
Thank you. It's been
We
great.
must get you back
Absolutely.
and talk more.
I would love to.
All right.
Thanks, guys.
Bye.